All right, hello everybody. Welcome back, of course. Center of Health Informatics, our virtual speaker series is happening once again. Thank you for joining us at this little bit of an odd time and an odd day. Usually we like to be a little bit further along in the month, but today we're doing it at a different time and date just because we have an international speaker with us today. So I would like to introduce you to our presenter, Karin Verspoor. She's from the University of Melbourne. She's a professor in the School of Information Systems at the University of Melbourne, the Director of Health Technologies and the Faculty of Engineering and IT, and the Deputy Director of the Center for Digital Transformation of Health. She will be moving on to RMIT in the next week or two, if I am correct in my remembering, to become the Dean of Computing. And her research focuses on biomedical text and data analysis, ranging from literature mining of biological events, analysis of social media for public health purposes, to predictive analytics and machine learning for medical applications. Today, she will be speaking to us about leveraging natural language processing in clinical decision support applications. All right, Karin, you can take it from here.
Great, thank you so much for having me. It's a real pleasure to be here. And thank you for accommodating the slightly unusual time. It is 10 a.m. here in Melbourne, and so it's actually a very comfortable time for giving a talk. So thank you for that. So yeah, I thought I would give you just basically a little whirlwind tour of some of the applications that we've been working on in the clinical natural language processing space, and motivate this work, I suppose, from the perspective of clinical data and trying to think about how we can leverage clinical data to support clinical decision making and actually other applications as well, such as population health studies. This probably is not news to any of you. We, of course, have massive digital repositories of health information available to us right now to record all sorts of information. And, this represents a really important resource that we're increasingly trying to take advantage of for patient care, for predictive modeling, and so on. As I'm sure you're all also aware, one important aspect of that data that we're trying to capture in the electronic health records is to make use of structured representation of information. So, we have this amazing kind of international collaboration around development of essentially language or codes for describing particular medical symptoms and phenotypes and conditions. And so there's a large number of examples of relevant coding schemes, such as the ICD, read codes from the UK, which I guess are being deprecated, but anyway, they were in use for quite a long time. Medical subject headings, of course, that you'd be familiar with from PubMed, SNOMED CT, and so on. And we have increasing efforts around standardization for computer-based documentation, all of which really opens up this opportunity to do data science, basically, in the context of health data, because through the use of kind of structured representation, we can start thinking about doing statistical modeling and analysis of those data sets. But we also need to make the observation that in the context of these electronic health records, we have a lot more than just those codes. And obviously, the codes are very valuable and they're used for many, many, many purposes. But we also capture structured data beyond those codes. So things like, vital signs and laboratory results and, measurements and so on that are captured in pretty structured form. And then we have this massive quantity of unstructured data, which is where I come in. So which is really where we need to start thinking about how we can leverage that data. And there's a little quote here that I like from Roberts, who says, while coding schemes might accurately describe a patient as a member of some group, they were never designed to describe the individual patient in detail. And where we get that detail from is from the clinical structure data, the more patient-specific data that we capture, and the unstructured data. So what is that unstructured data? It's all sorts of free text, basically, that's captured in the electronic health record. That can be things like a note on the reason for visit, daily progress notes that are captured either by a doctor or a nurse, letters that are sent between, say, a specialist and a general practice or a primary care provider, reports that come out of laboratory analyses. So radiology reports describing, for instance, observations of an MRI scan. Histopathology reports, again, summarizing, maybe cellular level analysis of a specimen. Discharge summaries, which attempt to summarize the episode or admission of a particular patient at a particular moment in time. And it's estimated that this unstructured data represents about 70% of the information that's actually captured in the electronic health record. And the reason for that is pretty obvious. We are human. Language is our most natural way of communication. And so trying to capture information and record information in terms of language just is a lot easier for us than it is to try to force those observations into codes and structures. Any of you who have worked with the codes know that you kind of have to learn the system in order to be able to use them. Whereas with language, we kind of, that's what we're learning our whole lives, basically from the time we're babies, is how to use language appropriately. And obviously we acquire more specialized language as we get older and as we train in particular areas, but it is still the kind of fundamental way we capture information and express it. So if we can come up with strategies to make better use of this information, then we can hopefully do a better job of supporting the data science of our health information. So looking at outcomes and prognoses, treatment effectiveness, and all sorts of research questions you might have, which eventually will be useful for direct clinical care. So just to kind of highlight this and give an example, here's an example of his discharge summary, which tries to capture a particular visit related to shortness of breath from a particular patient. And if you read through this, we can think of the information that's in there as in terms of kind of concepts and structures that we find in there, but there's actually a lot more detail that's available to us. So maybe let's think about how we can leverage that information. So by using methods from natural language processing, we can start to transform text like that discharge summary into models of patient history and patient journeys. We may want to capture, for instance, a timeline of clinical events that are associated with a patient in order to represent effectively the patient journey. And so that may consist of some structured information like diagnoses that are captured in codes. It may be prescriptions or procedures that are recorded in the electronic health record. But one key element of that is also observations that are made. And by and large, those observations are going to be captured in that free text portions of the electronic health record. One way that people have approached modeling text in general is to use what's known as a bag of words model. And in this kind of model, you take a sentence and you basically split it into words and you count how many times each word occurs in the text. And then your representation of the text is this list of words with counts associated with them. And this kind of model is very effective if all you're trying to do is get a sense of what's in the text. And actually, it turns out that this kind of model is useful for things like text classification. So, if you're trying to understand whether a text kind of relates to a general category of information, then this model can be quite useful. However, when we look back at that discharge summary, we find that there are phrases in there that are actually important, and they're important for capturing the kind of content of the text. And so we might instead, rather than thinking of this as a bag of words, we might instead think of this as a bag of concepts. And so we may try to identify particular clinical concepts that we're interested in, and in order to highlight those and then represent the patient observations in terms of those concepts. So in this case, we have phrases like shortness of breath. We have demographic information like 68-year-old female, which of course we can transform into a structured piece of information like age and gender. Sorry, not gender, I should say sex. That's a very controversial topic, actually, gender versus sex. So I won't spend more time on that, but anyway, trying to map into the categories that we assign. Shortness of breath, chest pain, chills. The notion of being admitted is important here, and something that we want to distinguish maybe from sort of general other words that are in the text, and so on. So we may want to transform this text into effectively a set of concepts that characterize the key information that is expressed in that text. And we have to deal with a few things along the way. So part of this is just, sort of like a dictionary lookup. If we know what the list of concepts is that we're interested in, we can try to find those phrases. And we have resources for this, like the Unified Medical Language System from the NIH, and a tool called MetaMap that they have built, which allows you to kind of recognize the sort of key vocabulary of the clinical domain. But we need to deal with things like variability. So there's different ways to express the same concept. Shortness of breath, dyspnea mean the same thing. We want to basically normalize those and group them together. We need to deal with some linguistic variation. So you can express the positive D-dimer test result in terms of either positive D-dimer, or you can say the D-dimer was positive, but both of those effectively express the same information. And so we need to be able to recognize that they are indeed different variations of the same concept or same piece of information. And we also need to think about what information we want to capture. So is it just symptoms? Is it just test results and demographics and therapies? Or do we also want to go a little bit more into the subtleties of the patient journey and capture things like the durations or the intensity of a particular symptom? I would suggest that in clinical decision-making, actually that information can be extremely valuable to the clinician. And if you look again at the discharge summary, you might draw the conclusion that just looking at it as a set of concepts or a bag of concepts is insufficient for really capturing that kind of clinical reasoning that is associated with this patient. And so if we want to get into the nuance of the patient description, then we actually need to go a little bit deeper and look at those concepts that might not be in those standardized vocabularies or lists of, the dictionaries that I was mentioning earlier. So things like the fact that a patient's shortness of breath, the symptom, is progressively getting worse and coming on with any kind of activity whatsoever. Again, this is nuance, but it is extremely important information because it's different when a patient has an acute symptom as opposed to something which is sort of gradually worsening. A cough being non-productive rather than productive is again important clinical information. Here, if we look at this and we just focus on the concepts that are mentioned there, we might think that that the patient has had a nuclear VQ scan because the text mentions a nuclear VQ scan, but then states that they've decided not to go ahead with that particular scan because the patient is too unstable for that scan. So we need to go beyond just the sort of simple concept recognition to understand effectively the relationships between the words here in order to have an accurate representation of what's going on with the patient. Okay, so how do we do that? Well, we are trying to do that through natural language processing methods, specifically methods known as information extraction, which basically relies on humans to tell us what is the important information, what are the important concepts and relationships that are expressed in certain texts. And then we try to build automated models which can find those in new texts so that we could potentially transform a whole electronic health record full of texts into more structured information that's a little bit closer to the relational structures that we might be interested in. And so we've been working on this in various kinds of contexts, and I won't say we've gotten to the stage of being able to capture all of that nuance that I was just talking you through, but we're really trying to, to add a bit more structure to what's in the text and go beyond just that kind of concept view of the text. So for instance, one of the tasks that was organized through the N2C2, the National NLP Clinical Challenges in the US, is family history information extraction. And so this is a task where we want to take a sentence like, he says his father might have died of heart disease, which might be captured, for instance, in a primary care record or in a consult note. And recognize that it's not the patient that has heart disease, right? It's the father of the patient that has had heart disease. And furthermore, that the outcome of that disease was death, right? Mortality from the disease. And so we want to transform a sentence like that into a kind of more structured representation of the key elements of the information that's expressed there. The family member that's been affected, the observation that's relevant, and the status. And perhaps other kinds of information like certainty, which are also expressed there. And so again, we do this by leveraging basically examples where a human has told us, just like we've done here, kind of what the key aspects of that sentence are, and then try to train models that given new text will pull out, we'll be able to effectively fill in a template like this one. And we've done this also in other contexts. So one context we've been working on with one of our local hospitals here called Barwon Health is to look at clinical letters in cancer. Specifically, we've been looking at breast cancer. And it turns out that in Australia, breast cancer and most other cancers are, of course, reportable. You must notify the cancer registry if you have a patient who is diagnosed with a cancer. But recurrences are not captured. And it was brought to my attention by my colleague at Barwon Health that really we have no way to track recurrence of cancer, and all of that information, according to him, is however captured in the clinical letters. So when a patient is seen for follow-up care by a specialist, the specialist will record the status of the patient and then report that back to their primary care physician. And so these are very, very valuable resources. And in fact, in that context between the primary care physician and the specialist at a health service or a hospital, they often don't have a shared EMR. And so the letters become, and we don't have a kind of patient accessible common portal here in Australia. There is something called My Health Record, but it's quite impoverished. I can talk more about that if you like. And certainly in the case of Barwon Health, they find that most of their patients have there's no way to communicate information between the hospital and the primary care doctors other than via letters. And so, we are trying to take these letters and basically look for the key information related to recurrence. And we've been going on a process of having the clinicians identify which particular concepts that they're interested in. So we defined that they're interested in particular clinical concepts and they're interested in follow-up. Recurrence was actually the key thing that we started off looking for, but luckily, at least for breast cancer, we found that recurrence was relatively rare. And so we needed to add in other kinds of things in order to make this meaningful. And then we have relations that we define that link the concepts. And in the end, we had the clinicians annotate about 731 sentences. I don't actually remember how many letters that was, but it's probably on the order of 25 or 30 letters, not a huge number, but enough for us to get a sense of the information that's in there. And we had them go through with a little tool called Brat and literally sort of highlight each of these concepts and label them according to that schema we defined and connect them. And then we use this data to help train a model, which will allow us to then find these concepts and relations in new text. And so the idea is that using a model like this, we can then effectively machine read through the letters that are going back and forth between the specialists and the primary care doctors, and hopefully flag some of those key relationships and concepts that are of interest, so that we can then do things like ask questions like, how many patients have had a recurrence of breast cancer in the past year or two? How many patients may have had a good response to a particular therapy or a poor response to a particular therapy, because that information is also captured here. Along similar lines, I have a PhD student named Brian Herr, who's actually a veterinarian. So he's not an MD PhD, but he's a VetD PhD student. And he's been working on antimicrobial resistance. And actually from an clinical NLP perspective, working with veterinary records is quite interesting, because the privacy concerns for accessing veterinary records are much, much less than in human health. And so we've actually found it a really nice way to kind of start working with clinical text at larger scale. And so Brian has developed a relationship with an organization called Vet Compass. They're here in Australia. They're also in the UK, that basically provides a common electronic health record for our pets and for veterinary practices. And Brian's been working with the free text in those records in the context of antimicrobial stewardship. And particularly, he's been using clinical NLP methods and these similar kinds of information extraction methods in order to track the usage patterns of antimicrobials that can be detected in these large data sets. And we're working with over 20 million clinical records in this context. So it really is a large resource from 181 clinics. And here's an example of one of the clinical notes. I mean, obviously pets aren't describing their own symptoms, but the clinical notes do capture observations that the veterinarian has made, and you have similar things as to what you would have in say a GP record for a human, where you have examination and maybe history that's not present in this example, but a laboratory assessment information and so on. And if you dig through here, you can find here the information about the treatment that was given. So in this case, the animal was given cefovecin at 1 milligram per kilo, and so by using a kind of concept recognition and dosage structuring strategy, we can pick out, okay, this record has told us that this patient has received this particular antibiotic at this dosage. And so the next thing that Brian's actually working on is to then also understand the reason for administration. And so we're going just that bit further into the records, not just working out what the prescriptions were, but also why. So what was the reason? In this case, it's because of concern about a skin infection. Sorry, ear disorder, apparently. No, I think it's skin infection. It must be a mistake. Anyway, so using this kind of clinical characterization, we've been able to actually track the use of antimicrobials across the country and get more specific, like how many prescriptions are being prescribed. We're also tracking which particular ones are being prescribed and at what levels. And so this is just an example to show that by leveraging natural language processing strategies, some of which are relatively simple, we can actually get a lot more information out of these records than you might otherwise be able to. Moving on now to other uses. We also have a body of work which is related to evidence-based medicine. And the idea here is to basically support the clinical reasoning that's required in order to decide how to treat a patient. And so if we think of a kind of an example here of a study where we have clinical evidence related to a particular antipsychotic, and the inclusion and exclusion criteria of that study are quite specific, right? So the study says, okay, it's only relevant to patients with schizophrenia, males only, and weight range within 20% of ideal weight. And I have a patient that walks into my office, and you know, this is obviously not a male, and probably not somebody whose weight range is within 20% of ideal. So the clinician has to make a judgment, right? Do the results of this study apply to my patient? Should I use this particular antipsychotic for my patient? And if so, at what dosage? And so, you know, this is, if you simply say, oh, just look at the evidence in the literature, well, guess what? There isn't any, right? Because nobody has studied specifically the case of women who are overweight. And so the clinician has to make an inference effectively. There may be a better way, however, and so maybe we can think about doing something that my friend Nigam Shah at Stanford likes to call patients like mine. And the idea with this is that we can leverage the electronic health record systems to try to find where my patient belongs. So if my patient is Miss Orange over here, maybe she's most similar to the purple people. And by then asking questions about the purple people and effectively, you know, examining through the data, the efficacy of and the outcomes of particular treatments, then perhaps we can get more nuanced information about how to treat Miss Orange and whether or not we should prescribe that antipsychotic. In order to do this, we want to leverage the full body of information we have about our patients. And so that means really also examining the clinical text and all of that symptomology that's captured in the observations. We can characterize our data in terms, you know, in normal terms, counting and statistical estimation and patient level prescription using the tools of data science. But in order to do that, we need to have transformed our electronic health record information into a more structured form. And so we can think about a concept that's been referred to as the green button, where we basically say, right, you know, we have this clinical situation. We, of course, want to look at the literature to see whether there's a randomized controlled trial or a systematic review or a guideline of some sort which can support our decision making. But if not, then perhaps we can use those tools of data science to help us do analysis of a particular subset of patients. And the key thing here is that you know, is finding the purple people, finding the people that are most similar to the patient that we're trying to treat. And we can use analysis of that cohort in relation to the broader population in order to help us make a decision about how to proceed. And so this is a very abstract concept, and I don't think it's been realized in any kind of concrete way yet. But you know, we're trying to build up the tools and techniques to kind of get us to that, achieving that vision. And because our focus is on the text, one of the things that we're working on is, okay, how do you find the purple people, right? How do you measure similarity between people? And we're taking the lens of what's known as semantic text similarity. So we're actually trying to come up with strategies and methods that will allow us to compute the similarity of patients in terms of the textual descriptions that are available about them. This leads us to some fairly contrived tasks. So one particular task that we've been working on is a particular task where we have sentences that have been paired together, and we need to assign a number to them that indicates how similar those sentences are. And so in this case, we have two sentences, sentence one and sentence two up here, that mean the same thing. But then, you know, kind of these two sentences here, if you read them, you'll find that there's some important information that's differs between them or that is missing. And so you might assign that as a similarity score of 3. And so my student Yusha has been working on basically that kind of sentence pair level assessment of similarity. And the idea is that once we can do that at a reasonable level, and she's getting better and better with that one, how could we combine that kind of approach to doing sentence level similarity to start establishing patient level similarity, or maybe more specifically visit similarity. And I'm not sure how well we're going to be able to do this, and there's lots of questions that we don't have answers to, so there's still plenty of research to be done here. We don't really know how the best way to combine information from multiple documents that might be associated with a patient, or even harder probably to combine information across visits. And then the eternal question of what's the best way to combine structured data that we might have in laboratory results and prescriptions and what have you, with this free text information in terms of our modeling. And the electronic health record data, because of the fact that even if it's time-stamped, it often can capture historical information. It is quite tricky and challenging to work with. But that's the kind of broader vision that we're working towards. And just to kind of close the loop on that, we're actually also working on the literature side of things. So how can we connect the phenotypic and observational characterization of patients with what's in those randomized controlled trials and systematic reviews that are described in the literature. And I'm have too many slides, so I'm gonna have to wrap this up pretty soon so you guys can ask some questions. But the idea with this work is essentially to transform the literature in the same ways that I've been talking about transforming the clinical texts, so that we can basically align these things together. And so we've been working on processing the literature, sentences like, accumulative COVID-19 related hospitalization and death rates, mapping those into particular PICO elements, population intervention control and outcome elements from the clinical trial structure, and then combining that with the same sort of concept recognition that we were doing in the clinical notes in order to relate particular concepts to particular dimensions of our trial structure. And the hope is that once we have kind of matched up representations of patients in terms of the concepts, and we can define effectively the population of a study, we might be able to relate that to the actual patients in our electronic health record. Okay, so this turns out to be tricky, and I won't spend a lot of time with this, and just flash up some examples so you can see why I have what I like to call job security. So lots of different ways to express the same concept. A concept like insomnia can be expressed all sorts of ways. Language is, of course, ambiguous. What does cold mean? Well, it could be low temperature, it could be a cold, could be a sensation. It's both productive and ambiguous. So we have all of these things coupling together. Language, as I mentioned earlier, is highly relational, and this is really important if you're going to start modeling the information. Shifting off Zantac to Nexium that has temporal information in it. The patient had been prescribed Zantac, now is no longer being prescribed Zantac, now is now from this point in time taking Nexium. And so if you're thinking about trying to model the information in the text in terms of a timeline, you really need to understand what a phrase like that means. Similarly, here we have temporal information about the duration of a particular symptom or two symptoms. And so we need to go deal with all of those things. Negation turns out to be something that most natural language processing systems ignore completely, because for most general English natural language process, or most general natural language processing tasks, it's not important. But in the clinical domain, negation is extremely important, because the whole process of clinical decision-making hinges on knowing what symptoms a patient has, in addition to knowing what they don't have. And so ruling out particular symptoms is or particular explanation for a symptom is extremely important. And so there's all sorts of fun ways that we can express negation that turn out to be challenging for our NLP system. We, of course, have to deal with the fact that these texts are often written very quickly, and they're not written for, machine reading purposes. And so they're written for particular purposes, often, for documentation, just so that it can be referred to on subsequent visits, but also for billing purposes and for other reasons. And so there are lots of fun things that happen because these are human generated that create problems for us. And the fact that they are created for different purposes can actually mean that the way the information is expressed can vary quite a lot. So capturing information for the purpose of documentation is not the same as for communication between medical providers, and you're going to give slightly different information and express it in a different way depending on what the purpose of the document is. And we're not really dealing with that very well right now, I'll say, in clinical NLP. One interesting little anecdote is that, in the US context, I don't think it's as bad in Canada, but in the US context, it's a highly litigious society. It's been found that the clinical notes actually vary considerably from other places internationally. And specifically, they have hugely long documentation in their electronic health record. And so this was a study where they showed that, basically the average internationally average ambulatory note was less than 2,000 characters in most international contexts, whereas in the US, you can have up to 7,000 characters. And this is, what you might call the CoCYA documentation requirement that exists in the US. If you don't know what CoCYA is, just Google it. I probably shouldn't say it on a YouTube video. So the corollary is that text reflects human behavior. And just to very quickly wrap up with a few challenges, our NLP algorithms, in addition to dealing with all of this kind of variation that we can expect and we need to deal with, we are never, we can't over rely on the algorithms because they're never going to be completely perfect because of the fact that you can't anticipate necessarily all of the noise that's going to be and all of the variation that's going to occur in the electronic health records. And the question of whether models developed in one context will generalize to another is actually still very much an open question. In fact, I'm doing some work right now where we've taken models that were developed in the US context for clinical text de-identification, which is another challenge I'll mention just in a sec. And we're finding that they just don't work on our Australian data at all. And that's for lots of reasons, but fundamentally because there are these differences in documentation practices. And so you can't just take an algorithm developed in one context and plop it into another and expect it to work. The privacy and the reason for us doing that de-identification work is a real barrier. So, while people have kind of gotten comfortable with sharing clinical data when it's in structured form because they feel that they can anonymize or de-identify the information that's in those records, and look, when we're talking about genomic data, I think you might ask a few questions about whether it's ever possible to completely de-identify that data. But anyway. The issues in clinical text, because of all of this kind of messiness and variation that exists in the text, it's a clear concern that there may be leakage of personal information. In a note, you might say something like, the patient's husband, John, accompanied her to the visit. Well, now you have a name, right? And it's not as easy as finding a name field in a structured resource. So that's one of the things that we're trying to work on. And there was support for this from I2B2, the predecessor of the N2C2 challenges, to pose as a challenge test for the community how we could identify personally identifiable information. And so we're working on that and adapting those methods here. So I'll just leave it there and just say, look, I hope I've convinced you that there are tremendous opportunities to leverage clinical texts using natural language processing, and that these texts are a significant and important part. And actually, we probably are never going to get rid of text. Like a lot of people want to say, oh, just put everything into codes, but I don't think that's actually ever going to quite be enough. But we do have some significant challenges. And, I will say we are making progress. I don't think we're going to have like, the Uber machine reading tools available to us for clinical text, next month or anything, but we are kind of working on particular kinds of problems and we're moving forward in a particular direction. So with that, thank you for having me, and I'm happy to take any questions you might have.
For more information on who we are and what we offer, visit our website at coming.ucalgary.ca/CHI. If you are interested in our services, collaborating with our team, or have any other inquiries, contact us via email at chi@ucalgary.ca.